Hello, I'm Dr. Tombly, and this short video is designed to help us understand kind of an overview of how much time a client should be expected to spend in treatment. So the standards that we use to make this determination come from the American Society of Addiction Medicine, the Comprehensive Substance Abuse Treatment and Rehabilitation Program, the Missouri Treatment Court Standards, and the Adult Drug Court Best Practice Standards put out by SAMHSA. All three of these organizations actually do, in fact, converge and have a common understanding of what treatment engagement looks like. So they all agree on some key principles of how do you structure treatment. First of all of them say a comprehensive menu of services is what's needed. That means we need to have a range of services that would be available based on what the client needs. Case management, mental health, just substance abuse, anger management, etc. These services are determined and built into a treatment plan. That treatment plan is based on a clinical assessment and is individualized. Again, the emphasis is that we are trying to find out what works for the specific client based on what the client needs and both the strengths and the needs of that client. And then that we provide multiple levels of care. So we adjust those levels of care based on the participant's response to treatment. So not everyone goes through the same level of care or the same number of hours in treatment. It really is individualized based on the condition of each participant. There are some other criteria that tend to impact the time a client engages in treatment as well. We need to use evidence-based practices. And so we can't just make things up as we go. We're using these practices and we want to make sure we're having fidelity to those practices. Are we providing co-occurring mental health services? Are there a need for mental health services? Are there trauma-related services that need to be provided? What about medical assisted treatment, family services, other ancillary services like job placement or housing? All of these things impact the number of hours that a client needs to engage in treatment in order to have these goals met. So let's take a look. The standard here is ASAM. And all the other organizations have really adopted this. In fact, the CSTAR program in the state of Missouri is moving to a full adoption of ASAM levels of care. And you can look at them, they're pretty intense. So I want to go through them pretty fast. It's what we have to do when we do an assessment on any client. We're going to recommend based on the 6 domains of ASAM. So ASAM levels look at any withdrawal risk, they look at medical risk, they look at mental health risk, they look at readiness to change, they look at risk of relapse, they look at recovery environment. Taking those 6 domains and measuring the risk factors at each of those, they come up with, the diagnostician comes up with what level of care. 3.5 is residential, 3.1 is a transitional living, so it's residential with a minimum of 5 hours of treatment a week. A level 2.5 is an outpatient with greater than 20 hours a week in treatment. 2.1 is outpatient with greater than 9 hours a week. And then level 1 is an outpatient with 9 hours or less of treatment. So where does theory and reality meet? Because oftentimes we find that there's a pushback because going to treatment isn't necessarily the priority that everyone makes or wants to make. They want to get a job, they need to get housing, and these are all realistic and felt needs that a client has, and they should not be ignored. However, I would argue that if they don't get traction and recovery, they're going to lose all those things, even if you provided them for them at the starting point. So I'm going to suggest something that might be a little bit easier to wrap our head around when it comes to how much treatment a client should engage in. And it's using all the standards that I previously mentioned, but it just frames it in a little bit of a different way. So you might think about it in this terms. It matters where the client starts. Okay, what is the starting point? And we determine that starting point based on the client's ability to maintain their own abstinence. So if they're unable to establish any pattern of abstinence, they go residential. If they're able to maintain a sporadic abstinence, say a pattern of 5 days or less, then they do 20 hours a week of treatment. If they're able to have 2 weeks to 1 month of abstinence on their own, 9 hours of treatment a week over 4 days. So we spread it out so they have multiple contacts throughout the week. If they're able to have 1 month to 3 months of abstinence on their own, 4 hours weekly over 2 days. And if they're able to have 3 months or more of abstinence, 2 hours weekly. This would be where they would begin, and then we would reassess at certain milestones. So we would reassess at day 30, at day 45, at day 90, and at day 120, and then when they met certain completion goals. So you think about intensity at where they start, and then you reassess at these milestones and reduce the number of hours. Now there's some other factors you have to keep in mind when you're talking about reducing hours, because we're using evidence-based practices like MRT, anger management courses. The number of hours that a client has to engage in treatment can't just change automatically at a 30-day mark or a 90-day mark. It would have to be as you come to an end of one of these treatment elements that the client is engaging. So I hope that helps give you an overview of kind of how treatment is kind of organized and the level of care and the time investment that we can expect from clients.